healthcare in Hawaii. I'm your host, Josh Green, physician from the Big Island, senator from Kona, and I also work with good physicians and nurses and administrators across the state on healthcare reform. Today I'm joined for a very interesting program. We're going to be discussing the Queens Clinically Integrated Physician Network. We also call that the Queens CIPN, so you'll hear us say that many times today. Over the course of the last several months, we've had an interesting conversation with many healthcare leaders across the state about the effects of Obamacare, the Affordable Care Act. We've talked about what HMSA does in our state. We've spoken with directors of health, human services. We've talked about hospice care. All of these interesting pieces of the healthcare system are trying to find their way to connect together. My two guests today are excellent people in the healthcare system. These are healthcare leaders, and they're working to integrate the entirety of the healthcare system. These two individuals have taken up the charge of clinical integration, and that's what we're going to speak about today. So first I'm joined by Amita Goyle, who's the director of the Queens CIPN. Amita, how are you?
Good, thank you.
Thank you for joining me. And then also John Howk, who's medical director at Hawaii Quality Physicians Organization, HQ, I like to say. John went to University of Illinois, Abraham Lincoln School of Medicine back in the day, and he's a patient-centered medical home leader. He was actually one of the individuals, weren't you, John, that founded the PCMH? We've spoken about that on several occasions with Hilton Rathel and the gang, but you were really one of the founders of that program. So I want to give you a lot of credit for that, and maybe we'll talk a little bit about that today. But the reason I've asked you, Amita and John, to come here today is because there's a lot of buzz out there in the community about how all of these things are going to come together, and you two individuals in particular struck me as the right people to talk to about what's going on at Queens and how we're bringing the doctors together. Does that sound all right?
Sounds good.
Okay, so why don't we start with you, Amita. Could you give us a little bit of an overview of what this CIPN is?
Sure. With healthcare reform, there's a lot of change coming down the pike. And basically, there is an ask of us to be more accountable, to improve the quality of our patients' health, to bend the cost curve, and to improve access for our patients. In our current reimbursement model, there aren't really incentives to drive that change. And so, Queens is set up as a tertiary and quaternary system, and we started thinking about how do we truly accomplish what we need to with the triple aim, given the resources that we have. We needed to extend beyond the walls of Queens and to align with primary cares and specialists in the community so that we can offer care across that continuum, that total continuum.
Let me have you pause there. I think John's the right person to ask about the triple aim. I actually haven't gotten into it in depth. John, do you think you could give us, Amita just mentioned it. Could you give us kind of the lowdown on what the triple aim is in healthcare?
Triple aim came out of Institute of Health Care Institute. I don't know if I've got it AHI exactly right, but Don Berwick. And Don Berwick, former Secretary of Health and Human Services, is really given credit for coming up with the triple aim. It's been the mantra for healthcare reform, I would say, for certainly the last 5 years. He coined it, I think, 10 years ago. And what it is, first of all, improve the patient's experience of care. Now, what does that mean? Basically, the quality of care that we give, the access to the care that we give, and to make sure that it's safe. So that's that experience of care, the first of the triple aims. The second one is to improve population health. And by population health, we mean for the doctor, it's not just the patient who arrives in your office today that you're responsible for, but you are responsible for a group of patients, your population of patients. In my example, I have, I think it's 1,560 patients who are my active patients who I am responsible for. So population health, the second of the triple aim. And the third one is to reduce or at least bend the rise in the cost of health care. So Don Berwick's triple aim, amazingly embraced by most people, most of the health insurers, the government, private industry, all have gotten behind that triple aim. and it's what we have based Queen's CIPN upon. We started with the triple aim.
So I so appreciate you saying that and giving us such a clear description of what it is, because on previous programs we've talked kind of abstractly about the healthcare system and some of the numbers that fly out. We know that, well, first of all, in our country we've had many individuals that were uninsured, and we're addressing that. But that isn't care, just to get people insurance, and I know you've been a champion to give people care. And in addition, we know that in our country, not just have we had many uninsured individuals, we've spent basically about $3 trillion on healthcare, and it's a challenge for the system to bear. And it's highly debatable about whether we should spend more or less. Like you say, it is now a part of this discussion and a part of the triple aim. So as we've spoken about those things, and we've watched the bill come down from Washington, D.C., and a lot of it trickled into our system, what I'm gathering is that people like you and you, John, are now kind of in the trenches working to deliver on the basic premise that Don Berwick put out and the premise of the Affordable Care Act, which is get people better care, get them primary care, and like you said, make them satisfied, bend that cost curve. Okay, so we're really witnessing today a translation of all of those abstract comments and bills in D.C., and we're now trying to do it. Is that fair?
Very good.
Okay. So now we come to you, Amita. You work at Queens.
Correct.
And there's all these doctors out there. We've got a couple thousand doctors. Kelly Withy has talked to us about the shortage of physicians and hard time coordinating physicians and what have you. What does the Queens CIPN do with those doctors? How are you bringing people into this system? And then we'll start getting into the details of what it's really going to be about. How do you find these doctors, and how are you getting them on board with this idea that John has described?
So I would say about 6 to 8 months ago, we sent out information on what the QCIPN is, what we're trying to accomplish, and we worked with some of the larger physician organizations, or IPAs, in the community to engage their physicians and join with the QCIPN. We had a tremendous response rate and got, I want to say, around 500, 600 letters of intent back in March. And more recently, we worked through those same 4 founding physician organizations and expanded and actually included 6 more IPAs to work with us, and worked through them to gain membership to join the CIPN. So we have over 900 participating physicians signed up as of September 2014.
And for our audience, when you say 900 or so physicians signed up, are they all on Oahu? Are they in the other islands? Where are they from? Because Queens is located here, but now Queens is expanding, right? Queens has a Big Island site, and they're over on West. So where are these docs?
They're actually throughout the state of Hawaii. So we've got physicians on Big Island, we've got physicians on Kauai, Maui, Oahu, and Molokai signed up. And those 900 physicians, the split are about 300 or so of them are primary care physicians, like Dr. Howk, and the 600 plus specialists.
I was going to get to that. Okay, so now we've established Queens has decided to take a lead. And they're doing it because they want to work on these issues that John described, triple aim. In my experience, it's been pretty difficult to get not just, the organizations to work together, but each individual physician to work on a project together. How are you guys approaching that? I mean, it seems it's encouraging to me. Before we get in our second part of our segment to what the actual model is and what you're going to be focusing on, how is it that you got 900 doctors to sign up to a program to somehow work together?
I think ultimately the reason why we've had this interest is because it's about doing the right thing. And people really want to do the right thing for their patients. Physicians want to do the right things for their patients.
John,
would you agree?
How do you think it came to pass that, because I think other organizations have tried similar projects and they got just smaller numbers of individuals interested. We've spoken with the Hawaii Pacific Health folks, and they do some great work. There's no question. We've had Ginny on the show. We're very fond of Ray and that gang. But their program hasn't caught fire as of now quite the same way the Queens program has. What's the difference?
I think physicians want to do the right thing and they want to provide quality care. I don't think any doctor wakes up in the morning and says, I want to go out and give my patients poor quality care. We have based Queen CIPN on quality, and we've really pushed the triple aim, population health, and improving the quality of care we give our patients as the #1 focus. In fact, that's the basis of our contract. For physicians to get together and to be able to even contract with an insurance company, we can't do that. There are laws that don't allow us to negotiate our fees, but we can organize together in order to improve the quality of care we give. And I think that appealed to doctors. And we went out there primarily not saying we're trying to keep our fees the same, or we're going to try to protect your practice. We went out there with our primary focus being to improve the quality of care. Now, having said that, doctors are very nervous about what's coming down the pike. And they knew that we're moving from a fee-for-service system to a system whereby it's fee for quality, fee for outcomes, and doctors don't quite know what that's going to be. And so let's join an organization that's trying to define what that quality is. So I think that appeals to doctors.
I think the other thing that is appealing is that we're not asking physicians to give up anything. They can maintain their private practices and partner with Queens. Other organizations, it may be a little bit more, where you have to make a hard decision on whether or not you want to be employed. This is just a partnership with Queens, an alignment.
Okay. I think that's a very good place for us to take a pause. Because I think you laid out kind of the fundamentals of where you're starting. But in our second segment, what I'd like to do is I'd like to lean on you both a little bit and ask you, okay, now that this large group of physicians have come together to work together towards better care for patients, better quality care, what exactly are those measures and how do we define them? So why don't we take a break now? I'm Josh Green, host of Healthcare in Hawaii. Thank you for joining us on this important program about the Queen CIPN.
My name is Alice Lee Hagan. I host the ThinkTech Hawaii BizEd Spotlight. We talk about fascinating people and interesting issues that affect our island state here in Hawaii. We broadcast every Thursday from 3 o'clock in the afternoon to 4 and on Olelo 54. Make sure you tune in and we'll see you soon. Aloha.
Aloha. Welcome back to Healthcare in Hawaii. I'm Josh Green, your host, emergency room physician from the Big Island. I work with the Hawaii IPA and at the State Senate as the health chair. Today I'm joined by Amita Goyle and John Howk, who's a physician. We're talking about the Queen's Clinically Integrated Physician Network. In our first 15 minutes, John and Amita were very good about describing where healthcare reform has started and gone. It started at the federal level, and we had this theory and this premise that we have a triple aim in our country to improve care, improve people's satisfaction of care, and to maybe keep costs under control. Now we're seeing it translated here at the local level, and Queens has stepped up. They've begun to work with people like Amita, who is serving, in this case, as the director of the Queen CIPN, and they've decided to translate all of these plans and premises from Washington, D.C. into actual better care here in the state of Hawaii. So thank you for joining us. I want to dive right in. We established there's 900 docs or so that are now going to work together. They're not going to give up their practices. They're going to still be independent. They can still work through their physician organizations, but they're going to come together in some kind of common purpose. So how are you defining and deciding really what the best things to work on are in our state? Where are you guys on this process?
So we started a year and a half ago on this process. Even though the membership has just coalesced in the last few months, the process of what we're going to work on began, I'd say, 18 months ago. And I have co-chaired with Rob Otani, the quality committee for these last 18 months. And I've been amazed. We basically asked doctors, the leaders at Queens Hospital, the leaders in the community, even folks from Kauai are on the quality committee to get together and to define or begin to define quality, and also to try to improve that broken healthcare organization that we have today. The first thing we tackled was, how can we do a better job of coordinating the care that we give? And a lot of times patients get lost between the primary care physician and the specialist. So we have come up with a referral form, a standardized referral form that has, what question does the primary care want the specialist to answer? What are the patient demographics, so that the patient doesn't get asked the same question twice or the same information? And all of that information then is transferred from the primary care physician to the specialist, and the patient is helped in making that appointment to the specialist. So we're trying to standardize that process when the primary care physician decides to refer a patient to a specialist. In the same way, we're putting down what the specialist needs to do to get back to the primary care physician. What data and how should he transmit that information back to the primary care in a prompt fashion. So we started with referrals, trying to do a better job of coordinating the care. And the next thing that we tackled were, what are projects that we can pick, that we can identify within Queens Hospital and in the community that would achieve the triple aim. And we basically just asked doctors that, the doctors in the Queens Quality Committee. And we came up with 5 projects. One of them is a pediatric asthma project, how to improve the care of pediatric asthma patients. What can they do in an outpatient arena that will decrease hospitalizations and decrease the emergency room visits by maybe doing a better job out there in the community. The second one was when patients come in with chest pain, pulmonary embolism is sometimes suspected. And kind of the gold standard for that diagnosis is something called, I don't want to get too technical, but a pulmonary angiogram, where they have to inject dye, do a CT scan to see whether or not you've got a blood clot in your lungs. It's expensive, a lot of radiation associated with it, and what we wanted to do is make sure that that test is given to the appropriate person, but not given to the people who don't need it. And then there are some basic things that you can do before you order the CT angiogram. Second project was to try to do a better job with that. The third one was testing for patients with chest pain. Before you end up with a cardiac catheterization, you want to do certain tests before you end up with a real expensive test. And there's various questions that you can ask, the history and the physical, that can really determine what kind of test you need. So we wanted to standardize that testing. The fourth one was the preoperative testing. If you are a healthy young person, or for that matter, even a healthy, somewhat older person, you don't need a lot of tests before you have surgery. A lot of the preoperative testing that's been done over the past 20, 30 years is unnecessary. So we're trying to identify which patients don't need that preoperative testing. And I think I've named 4, and I can't think of the fifth one.
Advanced care planning.
Oh, very good.
Tell us about advanced care planning, Amita.
So advanced care planning is about having conversations with patients about what are their goals when it comes to getting care. If they get sick, do they want to have everything done, or how do we manage the type of care that's provided to them? And having those discussions before they get to a point where they're very ill and admitted into the hospital, starting to have those conversations so that we can actually provide the right care to the patients, and so the families feel comforted too in those difficult situations, and they're not making those decisions in those difficult situations.
So it looks to me like what the committee did is you spoke, let me reiterate, you spoke to a bunch of physicians, so these didn't come out of the offices of administrators that don't provide healthcare. This came out of clinicians, thought processes, and you had a large group of healthcare leaders across the state, and you reached some consensus on some key projects that could make healthcare better. Maybe not all the projects, obviously, because I don't, for instance, hear any discussion today about, say, not being critical about diabetes, for example, where a lot of us are talking about diabetes and kidney disease. We've had shows about those things specifically. But you've seized on the moment of having a lot of physicians' attention that are working together, and you picked 5 or so projects that could begin to help achieve the AAA. People be a little more satisfied. They're not getting quite as many tests. They're certainly not getting unnecessary tests that are costly. They're not getting radiation like you described, Dr. Howk. Very good. And they're not getting care at the end of life that they maybe didn't want, which is, as we know, a big concern for people who are elderly, and they want not just to be getting the right care from the providers that they trust, but also I've been interested to find over the years a lot of patients really want to control their own health care at the end of life, and they would like to see some of those resources used appropriately for their children or their grandchildren. And all these seem to resonate not just in our healthcare system here locally, but also they will have some impact on, dare I say it, the bottom line, that we can then reinvest other healthcare dollars. Is that a basic description of the system?
Absolutely. And so what we did was we took all of the measures that Dr. Howk spoke about and built onto that and added additional quality measures and identified additional areas where we think it could be aligned with achieving the triple aim and creating proxy measures that would help us determine whether or not we're truly moving towards bending that cost curve and improving quality.
That's a good point. I was going to ask, how are you going to measure these things? Now that you have many doctors engaged and they're going to be focused, they'll get information about these 5 projects and the other measures, how will you measure and tell whether we've improved matters? How's that going to happen?
So we're actually working with HMSA, and because the initiatives are focused on the commercial lives for HMSA, a lot of the information we'll be able to work with them to get from claims data and other sources, and that's in the short term, in the first year. And our goal is to be able to come up with a system where we can have data analytics within the CIPN, which marries up clinical data and claims data for our population so that we can start to identify other areas to focus, such as diabetes, if that seems to be something that resonates with a lot of the patients in the CIPN.
So let me translate that a little bit. So you've got a relationship with, we've got Queens in a relationship with these doctors from all across the state. Leaders like Dr. Howk and Nadine Tensala and all these docs that, I think the guys at PMAG are doing great work. They're very involved. You've got them in the room. You reach out to HMSA and you say, okay, we would like to practice even better medicine. We as physicians have looked at some of the problems in our state and we have isolated these issues. Can you invest some resources in working on these problems? Is that correct?
Right.
Okay. And those physicians who participate as they want to join, I think I invited you today because we're coming to the end of the sign-up period for this first year. I'm sure there'll be many opportunities for people to sign up in the future, but we put together this cohort and HMSA puts down some dollars and they say, okay, have at it. How is that going to work? How are you going to determine who's doing a good job? Or are we going to ask the patients, were you happier? Were you more satisfied? How's that going to go, John?
Well, you've asked the most difficult question, and that's what we, have struggled with for 2 years, and I think that will continue to be a question that we're going to have to deal with. But what we've come up with so far is using some of the claims data. Let me give you an example. I mentioned the preoperative testing, and that patients who are at low risk should not have to have a bunch of tests.
Right.
So it turns out that when you put in a claim, an anesthesiologist puts in a claim, they actually classify the patient in terms of ASA 1, 2, 3, and 4, I think it is. ASA 1 and 2 are the low risk. ASA 3 and 4 are high risk. So what we're trying to do is, using those claims, figure out how many of those low-risk patients ended up getting unnecessary tests within 30 days before the operation. So that's what we call a metric, something that we can measure, and something that we don't have to go out and look at individual medical records, but we can actually collect it from the system that's already out there. So some of this data is already out there in these big computers, and we have to figure out how to mine it and look at it.
Okay. I think that's very valuable. I also take to heart these questions about chest pain and testing in the ER, because that's what I do for a living, and I know that it varies a great deal. I mean, in my little hospital, in fact, let me go so far as to say, on the entire Big Island, we don't have a cardiac catheterization lab. So honestly, nobody ever in those settings gets those very advanced invasive tests. So we've in many cases been forced to utilize the lower cost, less invasive examinations first before proceeding to a cardiac catheterization or open heart surgery or whatever. Now, we have very good partnerships with, so many of these terrific cardiologists over here on Oahu and on Maui and so on. But in some settings, by virtue of what was available, we've kind of backed into kind of checking our boxes, so to speak. But you're really taking it to a new level. You're expanding it statewide with the input of physicians to make sure we provide best care. Can the same be said of the advanced care planning? These are living wills. I think people talk about POLST. What does POLST stand for?
Physician's order for life-sustaining treatment.
Okay, thank you very much. So this is a question of what people will want services. So you'll also measure that. You'll find out what doctors are doing it when appropriate and how to improve. Okay, and then those who achieve will receive some of the resource to continue to invest in their practice. Is that about right? Mm-hmm. Okay. What's next on the kind of agenda for picking the next important issues to take on, next projects? You've isolated these 5. Is this the first year of the project?
This is the first year. We actually just started operationally by funding in August of this year. So we're actually in the first month.
Okay. Well, I think we're actually at a good time to take a break, and then we're going to go into more of the kind of operational, how's it going to affect doctors, how's it going to affect patients in their lives, so we can see the triple aim unfold in front of us. I'm Josh Green, your host of Healthcare in Hawaii. Thanks for joining us.
Okay, this is ThinkTech, and one of our favorite shows is Hawaii, the State of Clean Energy. And it goes 4 to 5 every Wednesday right here from ThinkTech in Pioneer Plaza at the core of downtown Honolulu. And my co-host is Ray Starling from Hawaii Energy. Ray, do you like the show?
I love the show. It's great to see all the new people coming in with new ideas about how to save energy, get us off of fossil fuel, and that's what it's all about. So Hawaii, the State of Clean Energy. See us on Wednesday afternoons at 4 o'clock.
I knew he'd say that. Thanks, Ray.
Aloha. Welcome back to Healthcare in Hawaii. I'm Josh Green, your host of the program, Senator from the Big Island and ER physician. I'm joined by Amita and John today, who are experts in healthcare transformation. They have worked with a large group of individuals over at Queens to form what we're calling the Queens Clinically Integrated Physician Network, or Queens CIPN. John and Amita have described to us that this is a part of the bigger picture of healthcare transformation. The triple aim has resonated across kind of the lips of many people in the healthcare system, and John was good enough to describe it. It's meant to give people better quality of care, better satisfaction, and to keep costs under control to some degree. But this isn't the only program that's going on. The Queens CIPN is building on other programs that have already been in place, and they're trying to make sure that they make good use of the hard work that's gone over the past 3 or 4 years. So I thought, John, this might be a good time to ask you about your work on the patient-centered medical home, because a lot of what Amita's been describing and you described today has, at least it sounds to me like, it requires a foundation, it requires some quality work, and I know that you've been very instrumental. Could you give us a couple minutes about the patient-centered medical home and maybe how that's going to tie into this program?
I really spent my career to establish primary care as the foundation of the healthcare system, so that everybody in America can have a primary care physician. So that when you get sick, you don't go run to a specialist first, but go to your primary care physician who really knows you, knows the nuances of your care, has been taking care of you for a number of years, and I think is the best person that you should see when you get a new symptom. Unfortunately, primary care has fallen on hard times. And there was a time back in 2009 when they were beating the death knell for primary care, just that underpaid medical students weren't going into primary care, residents weren't pursuing that field. And a number of people got together and started to think about how can we redesign primary care. And what has come up with something called patient-centered medical home. And it's not a new nursing home. It's not a home out of a physician's private residence. It is some people call it an advanced primary care. It's what we've always done, and that is do acute care, take care of you when you have pneumonia. It's chronic disease management, manage your diabetes or your high blood pressure, those chronic diseases, and do some preventive care. Make sure you get your mammogram when it's appropriate. Make sure you get colon cancer screening when it's appropriate. So it's those three things which primary care has done for years. But in a patient-centered medical home, we try to do that even better. In terms of acute care, do a better job with access. If you get sick, you go see your primary care physician today. Not in 2 weeks when he has an open slot, but you get in there to see him today.
Sure.
In terms of chronic disease management, there's diabetics who don't come to see their doctor. So we use these registries to identify which patients haven't been coming to see us. And then we call out and bring those patients in and get them to do a better job of taking care of their diabetes.
Sure.
And in terms of, chronic disease prevention, again, we use those same registries to find the people who have not had their mammograms, not had their colon cancer screenings, bring them into the clinic and get those done. Now, in a patient-centered medical home, we've also been given this other thing called population health management. Okay? You're responsible not just for the patient who's in front of you today, but for your whole population. And so we do a lot of work with registries. These are a list of patients with various diseases, and then we try to improve, how am I doing as a primary care physician managing my diabetics? I never knew that before. I kind of had a figure that maybe I was a pretty good primary care physician, but now that we have electronic medical records, we haven't even mentioned that one today. Now we have electronic medical records, I can actually pull data that says, how well am I doing? And this was really an eye-opener for me. I think it was 3 years ago when I first saw that. I have 110 diabetic patients in my practice. And when I looked at it, one of the measures that they use nationally is how many poorly controlled diabetics do you have? Those that have an A1C greater than 9. Well, it turned out that I had 12% of my practice of diabetics were poorly controlled. 12%. Is that a good number, Josh?
Hard to know.
Yeah, I didn't know.
But I assume you would love it to be 0%
Yeah.
under perfect circumstances.
I didn't know. But it turns out that nationally, it's like 40% is poorly controlled diabetes if you look across the nation.
Sure.
So that helped me to realize, hey, I'm not that bad, but also I can improve. And so that's one of the examples of patient-centered medical home using registries to do population health management. Queen CIPN recognized the value of patient-centered medical home. They recognized the value of putting the foundation of Queen CIPN in the primary care lab. So we really went out and said we want to build primary care into Queen CIPN, and we're so happy we've got 300 primary care physicians. Every patient in Queen CIPN, 180,000, has a primary care physician. That's huge. I mean, that's wonderful to start off with.
And it seems to me that this good work that you've done on patient-centered medical home, and you've added the public health aspect back into healthcare, is now being taken to that next level. I think in previous programs we've been able to describe that our resources in healthcare are often spent disproportionately on times when people are very sick, in the hospital setting, at the end of life, and I think you spoke very eloquently earlier to the coordination of care between these 300 primary care physicians and these 600, if I can do my math right, these 600 specialists that are now going to be in the Queen's CIPN. Also, in my research, about $4 has been spent in the hospital in Hawaii for every dollar spent in primary care. My numbers might be a little bit fuzzy, but a lot of money does get spent in the hospital. And it seems like now you, Amita, with your program at Queen's CIPN, are going to be able to blend the system to hopefully have an impact on how much money we spend in the healthcare system. Is that one of the purposes, to bring these two groups together, these specialists that haven't participated necessarily in PCMH, patient-centered medical home, and now in population health at the hospital level? How will that work?
Absolutely. There's always going to be sick patients who need to go to a hospital and need to be treated in that setting. What we're trying to really impact is those patients who maybe didn't need to go to the ER, maybe didn't need to get admitted. That admission could have been prevented if their disease was managed better in an outpatient setting. So what we're trying to do is simply keep patients healthier.
Gotcha. So you say we first focus on keeping patients healthier. Dr. Howk talked about maybe screening for their cancer sooner, taking better care of their diabetes, all of these issues. But we want to keep them healthier and keep them out of the hospital. What does Art say about that? When we tell him, sorry, Art, your hospital's not going to be as full. It's interesting. It's almost like it's a conundrum, it seems. Here you are, Queen's Clinically Integrated Physician Network, but you just said we're trying to keep patients healthier and keep them out of the hospital. How will our hospital doors stay open? How will that play out?
Yeah. I think one of the things that Art and other executives will always say is it's patients first. That is our mantra. That's what we're working towards, is keeping patients first. And so if it's the right thing to do to keep them out of the hospital, that's what we want to do. Like I said, I think there may be this demand destruction going on, but at the same time, the data that we see, there's this growth of need for healthcare, and it seems to be that the aging population is out there, and they're going to continue to need healthcare services. And so, really, we're not sure what's going to happen. There may or may not be demand destruction, and what we want to try to do is get the patients the right care in the right setting.
So if I was going to translate that again, and I think you've really spoken well about what the system is, there are uncertainties, but by forming a partnership between these 900 doctors statewide, through the leadership of the John Howks of the world, and Dean Tantasalas and Gray Heradas, and all these, the John Mortons, all these terrific doctor leaders, you've put together a coalition of the doctors, Queens, and HMSA, the biggest insurer in our state. And you've said, heck, let's get the patient's care put up front and first. And if we find that we don't need people in the hospital, let's take some of that money, some of those savings, and let's invest it, John, in primary care. Maybe he can do more screenings. Maybe he can have more staff to focus on the patient-centered medical home. Maybe we can have some extended hours at the office so that when someone is sick with pneumonia or cough or runny nose, they don't have to go to the ER. So what we're saying is these very respected institutions like Queens and other hospitals across the state are willing to take a chance on faith, basically, that if we bring all the right people in the same room, that we are willing to evolve with the healthcare system that's come from Washington and the Triple Aim. We're willing to spend our money and our resources elsewhere if that's the right thing to do. Is that a fair description?
Yeah, I think so. I think you said it well.
And what will happen when we save this money? How will we keep HMSA and Queens from saying, hey, thank you guys for saving the money, but we're not giving it to primary care? We have their commitment to invest?
Yes.
Yeah, absolutely.
Okay.
Yeah, this is just the beginning. we're not sure where the reimbursement model is going to be going. There are all kinds of models that are out there that can be contemplated: bundled payments, capitated payments, shared savings. In the first 3 years, what we've negotiated with HMSA is just a pay for quality, pay for value type of payment model that is above and beyond the fee-for-service revenue. So we're not touching the fee-for-service that physicians get, the professional component, the hospital gets at this point, but eventually we're positioning ourselves to truly be able to operate in an accountable care organization system and adopt to new payment models.
Okay, so you're saying you're ready to evolve, but first it's going to take a couple years to bring all of our doctors together. I've been admiring from afar how much effort you and John, and we should mention Whitney Lim, who is a physician leader of this program, have really taken to heart the physician input. John, we just have another couple minutes. What would you encourage physicians out there who might be watching our program or who are already participating in the CIPN to do? Do you need them on your committees? Do you need them to reach out to colleagues to sign up? Do you need them to give you new ideas? What would you tell them?
We need them on the committees. I think physicians can be part of the solution or they can be part of the problem. And so this is, I think, a once-in-a-lifetime opportunity. We're saying we're moving to pay for quality. They're asking us to define what quality is. This is your opportunity to define what quality is for your practice and to set those metrics and how you want to be paid based on that quality.
And I think for years, I so appreciate you saying that. For years, I've been one of them. We physicians grumble about what happens at the hospital level or at the insurance level, but this seems in our very Ohana-based state, it seems like our opportunity as physician leaders and as educated healthcare professionals to step up to the plate to say, we're going to define what's good for our patients. We're going to try to translate these large pieces of legislation and these acronyms. We're going to try to translate them into ways that make it possible for us to be happy with our practices, make our patients happier, and just maybe save a few bucks so that we can reinvest that into the good care for the people of Hawaii. I would remind people that we were first in the state for many things as far as health goes, first in the country, I should say, but we have a lot of improvement to do. And for every individual out there that's sick, I hope that they'll be able to benefit from the good ideas that you, Amita, and you, John, and the other healthcare leaders have put together. So thank you for coming today. I'm sure we're going to have future discussions about the Queen CIPN because it seems like it's in the first or second inning of the baseball game. We're still here in baseball season. But I'm so encouraged that there are healthcare leaders like you really pressing the leaders at the hospitals and at the insurance level and insurance companies to kind of take to heart what doctors want to do for their patients. So we'll call this our first discussion about the Queen CIPN, and then we'll come back together again. All right? Okay. Well, that's going to be it for our show today. I'm very happy to have had Dr. John Howk and Amita Goyle, leaders at the Queen CIPN, the Clinically Integrated Physician Network. In subsequent months, we'll come back to this topic and we'll talk about how this is going to make healthcare better for you and your patients in our state. Thank you for joining me. I'm Josh Green, host of Healthcare in Hawaii. Take care.